Yes, Dr. Samay, I'm here. Just let
Okay, King.
me.
The king is
I'm
here.
John.
How you
So I
doing,
have been
Uncle?
actually, I'm traveling and I'm not in my home to give you. I hope my presentations work. So let me see.
Okay.
Okay.
So you can see my presentation?
Yes.
Yes, it's okay.
Okay. So what I'm going to talk today is on my personal opinion about when to use a nasal approach and when to use a cranial approach. As we all know, endoscope is a very popular instrument these days. And of course, we have to learn endoscopic surgery. And I will encourage all young neurosurgeons to learn endoscope. But whether we are overusing endoscope and whether we are not using our cranial approaches, which we have developed over so many years, that is the subject of my discussion today. My opinion on when to use cranial and when to use nasal route. When I talk of nasal, I mean whether you want to use microscope or endoscope, that is immaterial, nasal or cranial. So you see, the whole brain is surrounded by a very firm and very resilient membrane called dura or dura mater. Matter means mother, mother dura. So the dura covers the brain and it forms a very strong partition or compartmentalization between the head and subhead regions, subcranial regions. So this dura is absolutely a magical material. And there are no holes in the dura. When there is a nerve, the dura goes along with the nerve. When there is an artery, the dura goes along with the artery. So there is no hole as such. And this dura has to be preserved and has to be respected because the tumors respect the dura. And the you see, this is the cella and how beautiful is the cellar floor and the anterior clinoid processes and posterior clinoid processes. What I have to say is the dura comes first, the bone comes later. Dura is stronger embryologically, and dura is stronger morphologically than bone. So bone is not as strong as dura. So the tumors can destroy the bone, but may not be able to destroy the dura. So this is a very important for a neurosurgeon who is going to operate on these lesions. So this is the dura of the diaphragm celli. This is the pituitary gland, and this is the pituitary stalk. There is a hole. This hole is not exactly a hole in the dura because dura continues. Dura does not stop. Dura is like a sheet of bed sheet. It is folded. It is not, it does not stop. And if you see the membranes from underneath, from the nasal root, you see these membranes are like mucosal membranes, and these are not as thick or as strong as the dura. So that is why cavernous sinus is an extradural structure. Both carotid arteries are actually extradural. So this controversy, whether it is dura or whether it is extradural, has remained for a very long time, whether cavernous sinus is extradural or intradural. But basically the premise is that dura is, you see, if you see this, there is dura above the cavernous sinus. This is dura, and the basal part is not exactly dura. the dura turns and dura forms the border of the sella. And this cavernous sinus is extradural. So to have this kind of anatomy is quite a beautiful, this is a cadaveric specimen, and we should never see such an anatomy during surgery, because if you see such an anatomy during surgery, you are certainly not going to be able to repair the dura and make it watertight. And this patient cannot survive, in my estimation. So you never, this is a cadaveric specimen. Pituitary gland has a special location. It is neither intracranial nor extracranial. It has its own special compartment. Cavernous sinus has a special compartment, special relationship with the pituitary gland, special relationship with the paranasal sinuses, special relationship with the carotid artery, very special relationship with the cranial nerves, which all have their own dura. This dural cover with, there is a dural cover with every cranial nerve. So this understanding of dura forms a very important understanding for our surgery. So there are several articles written by me about skull-base reconstruction, and I wish that you read some of these articles, because when we operate either by transcranial route or by nasal route, reconstruction becomes very important. Reconstruction, if we are operating from a cranial route, reconstruction is much easier than when we are operating from a nasal route. And the membranes, the various layers of the fascia, superficial temporalis fascia, deep temporal fascia, subgaleal fascia. You see, we had described this special layer called subgaleal fascia. And we can, subgaleal means when we talk of galea, we talk of subgalia, we always talk of fat. But there is a distinct layer called subgaleal fascia, which can be used for reconstruction. And it is very highly important that we use a vascularized pedicle reconstruction when we do a reconstruction either from the head or from the nose. So I have described several vascularized pedicle flap. This is muscle fascia flap. You see the superficial layer of temporalis fascia is everted, and a long facial flap, extended temporalis muscle fascia flap, multi-layer flap, vascularized osteomyoplastic flap, extended subgaleal fascia, pericranial flap, multiple layer facial construction of the middle fossa, and things like that. We have also described the use of outer layer of dura as a pedicle flap. So essentially what I'm trying to say is dura is an absolute waterproof covering of the brain. And if we are going to operate from the head or from the nose, this waterproof reconstruction of the dura is absolutely critical. Reconstruction of dura from the head is much more simpler, much more safer than reconstruction of dura from the nose. We have also discussed the use of mucosa, that is involving the sphenoid sinus for reconstruction, and reconstruction using cellular flow mucosa for as a vascularized flap. Many of you have heard me on several occasions talking about membranes, and membranes are mother, and membranes are, meninges are the mother of brain. And this is what we have derived from Arabic legacy. Alam al-Dimag means meninges are the mother of brain. Meninges come first, bones come later. Meninges come first, brain comes later. So meninges are absolutely primitive embryological formation, which the tumors respect. Dura is durable, and dura, about dura, we have written several articles which you will like to read. So when we are operating, We should not become expert in endoscope and we should say that every tumor can be removed from endoscope. That is an absolutely dangerous kind of philosophy. There are some tumors which we should remove by endoscope or by nasal route. Some tumors we should remove only by cranial route. And it is absolutely not correct to say that I can do from nasal route all these kind of tumors. And that I am going to discuss as to what my policy is when I will like to use nasal and when I will like to use cranial route. Long time ago, I had written about how the carotid artery is encased and how it is displaced. And this displacement or encasement will decide what kind of surgical approach you will take. This is my paper which I have written about 25 years ago. First, I will like to talk on pituitary tumors. Pituitary tumors, many of you are young neurosurgeons or young residents. This kind of pituitary tumor, about 25 years ago, everybody wanted to remove these tumors by transcranial route. Everybody used to do transcranial route. Nobody would even venture transnasal route. For the first time in the literature, we made a very important contribution in this subject, that dura of the diaphragm celli is elevated on the dome of the tumor. So this tumor is encased. Here is also dura. So this is completely an interdural tumor. There is no artery of circle of Willis inside the tumor. So this elevation of diaphragm celli is an absolute fantastic observation that we made 25 years ago. So grade 1 tumor is pituitary, where the diaphragm is elevated on the dome of the tumor. Prior to our discussion, what the whole world used to say is that the rent of dura for the stalk, this part of the tumor is subarachnoid and this part is subdural. So this description that the entire thing is within the dura allows us to do a nasal operation. So whether we use endoscope or whether we use microscope, that is not very critical. But this fact that if the dura is elevated, you remove the tumor, the dura will come into picture. So dural elevation, you can see clearly the dura is elevated on the dome of the tumor. So this information was not there 25 years ago. Even when you see this kind of nubbin, it is under the dura. If you see this kind of nubbin, it is under the dura. So the whole tumor is interdural or within the confines of the dura. If you do not have this understanding of dura, you come from transcranial or you come from transnasal, you will certainly most likely damage the person. So this kind of, you see, this kind of nubbin is within the dura. So the whole thing is within the dura. So this understanding is very, very important. Grade 2 is, when I call it grade 2, the tumor encases the internal carotid artery. The tumor enters into the confines of the cavernous sinus. And as I mentioned to you, this dura, you see the lateral wall of cavernous sinus dura is elevated on the dome of the tumor. This tumor does not transgress the lateral wall of the cavernous sinus. So this tumor under the diaphragm, under the lateral wall of cavernous sinus. Now, what area, how it transgresses the medial wall of cavernous sinus, whether it is interdural or whether it is extradural, it is a little bit of a controversial subject. But what happens is the whole tumor is under the diaphragm dura and under the lateral wall dura of the cavernous sinus. So there is a dural confinement. So no matter how big this tumor becomes, there is dura here, there is dura here, there is dura here. So understanding of the presence of dura will allow you to do a transnasal operation. So dura may be stretched, but dura is intact. You see the dura is stretched, but it is completely and entirely intact. Here you see, if you see this picture, there is entry of the tumor into the cavernous sinus. Here there is entry into cavernous sinus, and dural roof of cavernous sinus is elevated. Diaphragm is elevated. So this elevation of dural roof, it is very important to understand that this elevation of dural roof of cavernous sinus, if you have this understanding, you can remove it by the nasal route. So my understanding is majority of the tumors, pituitary tumors, should be removed by nasal route, and transcranial route is not a good option. So you see the dura of the roof of cavernous sinus, dura of diaphragm. Clearly you see the dural elevation, roof of cavernous sinus is elevated, the diaphragm is elevated, the roof of cavernous sinus, dura, diaphragm, roof of cavernous sinus. So there is a method in the aggression of these tumors. There is a method in the madness of these tumors. They have a confined kind of extension. Very rarely these tumors transgress the dura. And when they transgress and encase the arteries of circle of Willis, I like to call them aggressive tumors. And the surgical philosophy for these tumors is completely different from other types of tumors. So this gradation of mine about the dura, about the dural confinement is absolutely important. And I have no hesitation to say that the popularity of transnasal route for all these kind of tumors is because of the understanding of the dural membrane. You remove the tumor and the dura will fall into the picture. How you understand the walls of cavernous sinus, how the cranial nerves are displaced by the tumors have to be clearly understood. If one understands this concept, I think the surgery of pituitary tumor can be completely a nasal surgery and not a transcranial surgery, except for grade 4 pituitary tumors where the surgical options are of different kind. So this is the elevation. You only remove the anterior wall of the sella. There is no need to remove the planum sphenoidal or tuberculum celli. Remove the anterior wall, debulk the tumor, and within 10 or 15 minutes, the entire tumor, the diaphragm will be in picture, and there may not be any need to even do a skull-base reconstruction. There is no need to take any vascularized flap or anything if you preserve the dura. So transcranial route is a very important route. Like this fetus, the uterus is a very strong structure. It pushes the baby out. So these cesarean sections may be good, may not be good, but the understanding is that the dura is as strong as the uterine muscle, and the dura is as solid and consolidate structure. So this is, you take an incision in this cellar part, debulk the tumor. Many of these tumors are soft tumors. Many of these tumors may be vascular tumors, but the thing is, debulk quickly. There's no need for coagulation. And within 10 or 15 minutes, you can remove this tumor completely and beautifully. So these tumors are essentially non-functional tumors. And once you remove the tumor, the vision comes back and you give a new life to the patient. This kind of subfrontal extension was a classical indication for transcranial approach, but understanding that the dura is intact, you can, and how to bring this part of tumor into the field has to be learned and has to be acquired. Even when the tumor goes right up to the corpus callosum, you just work in this area, and get the dura into picture. And if you realize, I did this case 22 or 23 years ago, and at that time, 100% of time, this tumor would have been operated by transcranial route. But this understanding of the dura made me remove this tumor by a transnasal route. I did this operation 24 years ago, just taking incision and removing the whole of tumor, and this tumor beautifully removed by understanding of the dura. How the cavernous sinus portion of the tumor should be removed is absolutely another chapter, but understanding that the dura is intact, these tumors are soft, and these tumors which involve the cavernous sinus have to be removed transnasal surgical route. You see this part of the tumor, you can enter. About 21 years ago, I removed this tumor and I entered into the cavernous sinus, and this part of the tumor was removed. So understanding of the dura is an absolutely critical, and my opinion is firm that pituitary tumor should be removed, whether endoscope or microscope. I use only microscope, but endoscope is a good tool. This kind of tumors which encase the arteries is another chapter. So I've got several articles on pituitary tumors and I wish you can read it. This is one tumor which is nasopharyngeal angiofibroma. Even when they become large, even when they become huge, they remain extracranial and extradural. They never enter into the confines of cavernous sinus. You can make a beautiful plane of dissection, and these tumors should be removed by a nasal route. There is no scope for removing these tumors by transcranial route. These are nasal operation. I had described in 1994 an extended transcranial route for these tumors, but today I am saying there is no way, unless it is extremely massive or unless it is going right in the infratemporal fossa and beyond, maybe transcranial route may be an option, but in general, nasopharyngeal angiofibromas should be removed by a nasal route or extended midfacial degloving operation. Now I want to talk about meningiomas, and meningiomas is our life, meningioma is our subject, and meningioma is a very common lesion that we deal with. So in 2002, I described 70 cases. Now my experience is beyond 300 cases, which is the largest series in the world. Olfactory groove, this is the largest personal series in the world. So on the basis of my 40-year experience in neurosurgery, I will like to give you my opinion about tuberculum celli meningiomas and about olfactory groove meningiomas. And as you must have heard, that many people like to do tuberculum celli meningiomas, and even some people are nowadays describing olfactory groove meningiomas to be removed by a nasal route. I am telling you, my opinion is absolutely clear that there is no way, under no circumstance, you should remove these tumors by a nasal route, which is an absolutely dangerous surgical operation. So this is one meningioma. This is a little larger. This is a little bit more bigger. This is a little bit wider. This is little away from the sella. Now you see there is a opening here in the region of the sphenoid sinus, in the region of paranasal sinuses. And many people would like to do a transnasal route. I am saying under no circumstance you should do tuberculum celli meningioma by a nasal route. It is absolutely irrational and absolutely wrong operation. You will ask me why. I will like to explain to you. So this tumor is within the chiasma and the sella, can involve the carotid artery, can go lateral, can have a calcific rim. You see, these are various types of tuberculum celli meningioma. They encase the internal carotid artery and anterior cerebral artery complex. They may be very heavily calcified. They may have edema around them. So understanding of tuberculum celli meningioma is very important. Understanding the relationship of tuberculum celli meningioma with anterior cerebral artery is absolutely critical and crucial. If you have to attack a tiger, you have to attack up front. You cannot hold his tail and start pulling it. You will never be able to attack a lion like this. You have to understand the capabilities of the lion. And if you understand, these tumors may look like flower to you. So on the basis of various kinds of tuberculomas, we had made a gradation system of tuberculum meningioma on clinical parameters, when they come with convulsion, when they come with visual deficit, when they come with severe visual deficit, moderate visual deficit, duration of deficit, and various other radiological like calcification, encasement of arteries, going into the sphenoid sinus, extensive edema, and things like that. We had made a classification of tuberculum meningioma up in 2002. So 20 years ago, I had published this 70 case experience. So when you are going to operate on tuberculum meningiomas, the most critical and most important thing is anterior cerebral artery and its perforator. I have to tell you, with my experience of more than 300 cases, if you take one perforator of anterior cerebral artery, you can clearly damage the person. You can damage the person like absolutely you can create hemispheric deficits. So you come from front, you come from subfrontal, debulk the tumor, identify the optic nerve, debulk the tumor. At all times, you have to isolate the anterior cerebral artery and its perforator. Many a times they are very badly stuck to the dome of the tumor. If you come from the nose, this one perforator you damage, these which you will see at the end of the operation, and it may not be possible for you to control the bleeding. It may not be possible for you to repair the rent. It may not be possible to save the patient. So in my estimation, these operations, transcranial, are so simple and beautiful. Many of these operations can be done in 15 or 20 minutes, or half an hour is a very long operation. Come subfrontal, open the Sylvian fissure, relax the brain, identify the optic nerve, debulk the tumor, then identify the anterior cerebral artery, identify the perforators, protect the perforators, and go on debulking and resecting the tumor. So this is one beautiful tumor to operate by transcranial route. They are quick. They are never hugely vascular. They are, sometimes they can be firm and gritty in consistency. Never in my 300 cases I have ever damaged the pituitary stalk. The Lilliquist membrane is very strong. You don't have to go beyond the Lilliquist membrane, of course. And there is a beautiful arachnoid sheath which separates the pituitary stalk. And these tumors have to be debulked. Anterior cerebral artery has to be identified and separated. And these, even when there are calcified tumors, these kind of tumors, I will say, is an absolutely irrational and may not be a correct operation to do by the nose. And there is no question of having a CSF leakage when you are coming from the transcranial route. Debulk the tumor, learn the art of breaking the tumor, learn the art of demolishing the tumor without doing any major coagulation. So that is my opinion about tuberculum meningioma, that there is no way I will recommend, even when it is seen. And I will not, people may have their opinion, and they should have their opinion, and they must have their opinion. But my opinion is absolutely clear for me that these tumors are cranial operations, and you have to do by cranial route and not by nasal route. So we have done several of these cases over the years, and we have enjoyed this operation. Even when they go lateral and anterior cerebral, then of course you have to go lateral. But basically my surgical strategy is subfrontal operation, identify. I hope I can show you the video if possible, but I'm not sure. Maybe at the end of the operation, I will show you the video. So suprasellar meningiomas are difficult operations, but do not make them more difficult by doing them from the nose. So my opinion is that tuberculum meningiomas, olfactory group meningiomas are very fantastic cranial operations, and you should not do this kind of operation if you come from the nose and start using your endoscope and say, I am expert in endoscope, I can do anything from the nose. I think you can do anything, but don't do stupid thing from the nose. Come from front, do a smallish craniotomy, retract the brain, debulk the tumor, make the arteries safe, make the cranial nerve safe, and remove these tumors. So majority of these tumors nowadays we remove by only unifrontal approach. There is not even need for bifrontal approach. Most of the time is spent on breaking the tumor and not in the approach. So if you do any kind of nasal approach, I think it is an absolutely wrong, and I don't believe that this kind of nasal approach should be done. Even foramen magnum meningioma, I have seen some people recommending a nasal route. I will say under no circumstance I will do a nasal approach for a foramen magnum anteriorly placed meningioma. You do a smallish craniectomy, do a little bit of hemilaminectomy, have the vertebral artery under control, learn the art of breaking the tumor between the cranial nerves. So my opinion is absolutely clear. My opinion is absolutely firm for me. Doing nasal root surgery for foramen magnum is a absolutely unwarranted and unnecessary approach, and making a, running behind the mouse from a different direction is not such a great operation. So we have done all kinds of foramen magnum meningioma by a smallish route, by a posterior midline operation, midline posterior suboccipital, not even lateral, not even, there is no need for exposing and displacing the, mobilizing the vertebral artery. Even these kind of ossified tumors, I would like to show you some tumors. This is a meningioma in front of the brainstem. It is completely, you see on CT scan, it is completely ossified. I did a smallish craniectomy here, worked within the cranial nerves, learn the art of breaking all kinds of tumors, and you will be able to remove this tumor. This is another ossified tumor right in front of the brainstem. You see how the vertebral arteries are encased by the tumor. And if you say very good from the nose, I will remove the clivus and I will come from the nose, I will say absolutely rubbish kind of thing you are talking about. You break the tumor, protect the arteries, protect here, both the vertebral arteries are encased within this ossified tumor. So you have to, you have to protect the arteries, protect the nerves, protect the, and remove the tumor. This is another ossified tumor. You see how it is, and you can do by cranial route. So in general, for all meningiomas, foramen magnum meningiomas, tuberculum meningiomas, olfactory group meningiomas, my opinion is clear. My opinion is absolute. About craniopharyngioma, my opinion about craniopharyngioma is majority of craniopharyngiomas are very beautifully removable like a placenta. You hold the tumor and you can remove the tumor. But the issue is any problem with the arteries here on the dome of the tumor can be a big problem. If you come from the nose and you damage one artery here and there, it can be a difficult operation. So my opinion about craniopharyngioma is it is a straightforward operation because there is a clear margin of dissection and you can remove this tumor even by the nose. But if you ask me, my opinion about craniopharyngioma is when the sella is huge, you do a nasal route. When the sella is small, you do a cranial route. So this is sella is small, you don't come from the nose, you come from cranial, work interoptic or work from lamina terminalis and remove this tumor. So if I can show you this video, I'm not sure, but unfortunately my videos are not working. So meningiomas of various types, important is learn how to remove a tumor. And my beauty for with my surgical experience, I have worked in public hospital, charitable hospital, where many cases we have been able and fortunate to be able to operate. So this was in 1993, this was in 1995. So cavernous sinus has been my very important forte over the period. And most important is to understand the meningeal architecture of the cavernous sinus. So we had first described extradural approach to cavernous sinus, intracavernous sinus tumor for the first time in the literature, tumors. Of course, Vinko Dollens had described vascular lesions, but this was tumors. So trigeminal neurinoma, which is, as many of you know, is my very favorite subject, we described that trigeminal neurinoma is within the dural confines or interdural in location. The carotid artery is displaced medially by the tumor, medially. And the nerves of the trigeminal nerve are displaced on the dome of the tumor. Carotid artery is displaced and the dura protects the carotid artery. Dura protects the third nerve and the fourth nerve, and the dura protects the sixth nerve. The sixth nerve is displaced medially by the tumor. So more recently, I have been watching some webinars and watching some opinions that many people are saying that I will remove trigeminal neurinoma from the nose or by endoscope. My opinion is absolutely clear. It is not necessary. It is dangerous to remove trigeminal neurinomas from the nose because the carotid artery is medial, the sixth nerve is medial, and also the cranial nerve fifth is in an uncertain position which you cannot. So you come from lateral. There is no need to come from medial. So in 1995, we described, about so many years ago, you can see that we described surgery on trigeminal neurinoma on the basis of dural, interdural approach by just opening the Meckel's cave. So this is infratemporal lateral approach. Open widely the Meckel's cave and work within the dura, work within the dura. Don't go outside the dura, debulk the tumor, and then save the cranial nerve. So we remove this. Samay. So this
We have
tumor
muted.
was that?
We got it.
Okay,
Okay.
okay.
So when the tumor is even going to the posterior cranial fossa, we removed in 1994 this tumor by just opening the Meckel's cave. So understanding of the dura is absolutely critical. This type of tumor, many people nowadays are talking about transnasal route, but it is not a good option because the sixth nerve is uncertain, carotid artery is uncertain, and you come from lateral and remove this tumor. That is my opinion. So my opinion about trigeminal neurinoma of this kind is don't come from the nose. Come from lateral, open the dura, work interdurally, and you can remove these massive tumors beautifully in a very systematic and designed fashion. Trigeminal neurinomas, of course, for larger tumors, I have discussed about extended basal approaches. Now I do very smallish craniotomy and do by splitting of the temporalis muscle. This is my current, this kind of tumor. I just make a small craniotomy, understand the tumor, break the tumor, debulk the tumor, and then identify the cranial nerves and separate and save the tumor. And you have to improve the trigeminal sensation. This kind of improvement of the trigeminal function was first described by us about 25 years ago. Before that, nobody talked about improvement of the trigeminal function or improvement of the sensations of the face. So trigeminal neurinoma is a very fantastic skull-based operation. Don't make it nasal, make it cranial, work within the dura and understand the dural confinements. These, even when there is a nubbin, it is within the dura and you work in that direction. You see, this tumor can break the anterior clavicular process. If you say, I will remove the anterior clavicular process, not necessary. You will say, I do petrosectomy, not necessary, because the tumor itself does. So when the tumor goes even extracranial, there is a dura, and that has to be understood. And if you understand this dural, these tumors may not be required to be done by nasal route. Make a small opening lateral and work within the dural membranes. So even when the tumor recurs, it remains within the dura. Now I want to talk of another tumor This is cavernous hemangioma, and many of you have heard me talking on this tumor. These are the most vascular tumors, most benign tumors, and they are completely in the confines of cavernous sinus. And they have very characteristic radiological picture, goes up till the orbit, Meckel's cave towards the cavernous sinus, intercavernous sinus. They never touch the pituitary gland. So this location has to be understood. Now, this location is very close to paranasal sinuses. If you don't realize what tumor you are going to operate and you are coming from the nose, there will be there can be a surgical disaster. Never do this operation by a nasal route. And those who are saying I can remove this tumor by a nasal route, maybe either very highly expert people, or they are they don't bother about the tumor that they are operating. My opinion is absolute. You understand these tumors, they have very characteristic radiological picture, they are heavily vascular tumors. If you go from the nose, you may not be able to control the bleeding. Very characteristic extension towards the sella, towards the Meckel's cave, towards the orbit, encasement of carotid artery. These tumors have to be removed by an extradural lateral approach, which we describe for the first time in the literature for these tumors. And my opinion is absolute, and there is no question that transcranial route, subdural is not a good option. Extradural route is a beautiful surgical for these difficult tumors. And if you want to see the anatomy of these tumors in a panoramic fashion, these are the tumors you will see cavernous sinus in a very fantastic manner. So we described our experience with 45 cases, which is the largest experience in this area. So this is one. Okay, this one, unfortunately, it is working. So I am working within the, you see, I have opened the extradural. It is an extradural operation. It is a vascular tumor. It will bleed, and you have to open it and then, wait. And then deep, there is no, you see how furiously it is bleeding. But and this is, this operation was done in 15 minutes. It is an unedited tape, actually. I have just gone a little bit ahead, and I'm showing you this bleeding. If you are ready to accept and control this bleeding, you can do this operation. And if you start this kind of extensive bleeding from the nose, you will create a panic situation in the theater. And you see this there is an inferior lateral trunk of the carotid artery in the cavernous sinus, which is the principal supply of these tumors, which you have to coagulate. And to coagulate this from the nose may not be a possibility. So these cavernous, and you see how the bleeding is under control, and without much coagulation, you remove the tumor. Sometimes the tumor is supplied by McConnell's capsular artery and sometimes by meningeal artery. But basically, you have to remove these tumors quickly, and you give a new life to the patient. You have to work over the carotid artery because the sixth nerve is displaced lateral to the carotid artery. So these tumors come with headache and come with very severe diplopia. And you see this patient is having third nerve and sixth nerve. And this is the smile after about 2 months of surgery. And this person is cured. So if you want to operate on these tumors, there is only one route, transcranial route. And if you talk about any other route and endoscope, I am master of endoscope, I am king of endoscope, you will be king of disaster if you do with that kind of operation. Chordomas. Now I want to give you my opinion on chordomas. Chordomas are tumors which destroy the bone and displace the soft tissue. Carotid artery is displaced anteriorly, cavernous sinus is displaced superiorly, and they are essentially extradural tumors. So when there is extradural tumors, nasal route is a good option. I am not saying nasal route is not a good option, but transcranial is a fantastic option and should not be left for those tumors that extend laterally. So these tumors, if you come from nose, you may not have a good control of the carotid artery. You do not have a control on the sixth nerve, which is so important. So nasal, I will say, if you ask me, what is your approach for chordomas? Whenever possible, transnasal approach is a good option. Endoscope is a good option, but transcranial is a better option in a number of these cases. You see, carotid artery is displaced anteriorly in this chondrosarcoma. I described this in 1995. There is destruction of the clivus and carotid is displaced. So we describe middle fossa subgastrian ganglion approach. Lateral, carotid is displaced anteriorly, carotid is displaced anteriorly, dura is displaced posteriorly. You work in this direction, identify the sixth nerve early in the operation, and you can save it. The problem with transnasal approach is that the sixth nerve is displaced posteriorly on the dome of the tumor, and you may have difficulty in identifying this nerve. So chordoma is a beautiful operation. If you, here you see how much I have done this by a lateral approach. See how the carotid artery is under my control, how the cavernous sinus is under my control, how the clivus is under my control. How on earth you can get such a control by a nasal route? So chordoma's nasal route is a good option in a number of cases, but transcranial route cannot be neglected because it has its own beautiful advantages. We recently described supracerebellar approach to clival chordoma. You see this tumor, and if you come from the nose, it is very long distance. Come lateral, you may be a good option, but what we did was came from supracerebellar. The sixth nerve is displaced medially and on the dome. Identify the sixth nerve early in the operation, and these tumors are like jelly-like tumor, and you can remove these tumors beautifully by supracerebellar surgical route. Even this tumor, of course, can be removed by nasal, can be removed by endoscope, but we had done at that time a supracerebellar route. Advantage is that you can identify, isolate, and protect the sixth nerve early in the operation. So thank you, my dear friends. I hope I have been able to give you my opinion on what I will do in what kind of cases. Basically, my message for young people is that you must learn endoscope. You must learn the art of using the endoscope, because many a time you will get opportunity to use that tool, but don't be a prisoner of that tool and don't start using it for all the indications on the planet. It has specific indications. Never use it for tuberculum celli meningioma. Never use it for olfactory groove meningioma. Never use it for trigeminal neurinoma. Frequently use it for chordoma. Always use it for pituitary tumor. Never you can use it for cavernous hemangioma and things like that. So thank you very much, my dear friend. And Samay, over to you.
Thanks a lot, dear Professor, for the excellent presentation. Is there any question from panelists? I think you have made it more clear than enough. That's why we don't
No,
see.
I want to hear some questions. I'll be happy if there are some questions.
So my own question about how to make sure that dura is intact during
No, dura will, you must, that is the issue. You must know the power of dura. You must know that the dura is absolute. And if you do not know dura is absolute, it will be a very difficult operation for you. That I have to tell you.
So no tips and tricks to identify it from MRI. It's just a feeling or
No, you see,
what?
every tumor has a different relationship with dura, and that dural relationship I have described, my dear Samay, and that is the thing.
But no show sign that it's
No, it is
really
sure shot. You sure shot. Like pituitary tumor, the diaphragm will be elevated, work under the dura. Trigeminal neurinoma, work under the interdural. Cavernous hemangioma, always surrounded by dura, work within the dura. All these tumors have defined dural layers. Dura is mother, dura matter. And mother, these tumors respect their mother. And when we are operating as a surgeon, we should respect the mother dura, and work under the dura. And the
Yes,
tumors will respect, and we should respect. That is my argument. Okay, Samay?
yes, yes, but you said in grade 4 it doesn't respect. So how did
Yeah,
you?
grade 4. Then the arteries will be encased. Artery of circle of Willis, grade
Mhm,
4, it goes beyond the dura and
mhm,
it encases the artery. So those people
mhm,
who do not respect the mothers are
mhm,
aggressive people. And
mhm.
those people should be treated in an aggressive fashion. And those are dangerous tumors. So we are still working on how to remove those tumors. Basically, grade 4 pituitary tumors are very frequently hormonally active and prolactin level may be high. So you should always, there is a possibility of treating with hormone related drugs these kind of tumors. And whether to take biopsy only for those tumors or whether to use aggressive surgery is a controversial subject. Samay.
Okay, is it possible to resect grade 4 totally?
It is possible and but it is quite a dangerous kind of, you can kill the person also. So when you are going to operate, if you are going to be aggressive, because the perforators are also encased, and you can actually be a very, very dangerous kind of situation.
Okay, thank you, dear professor, for excellent presentation and discussion.